A very warm welcome, everyone. I'm absolutely delighted to open this episode 92 of the Royal Society of Medicine's COVID-19 webinar series, a series for health professionals by health professionals. I'm Professor Maggie Ray. I have two titles for today's session. I am President of the UK Faculty of Public Health, and I'm also recently President of the Epidemiology and Public Health section of the Royal Society of Medicine. It's a great pleasure, as I say, to welcome you to today's session, and it is truly an honour to be interviewing Professor Tim Spector. I'm sure, Tim, you are well known to our audience today, but I'd just like you to introduce yourself, please. Thank you.
Hello, everybody. I'm Tim Spector. I'm Professor of Genetic Epidemiology at King's College London, and I'm also the lead investigator, along with many other people, of the Zoe COVID study and app.
Thank you so much, Tim, for joining us. I have to say we've got a fantastic audience today, and we've already had some really outstanding questions that this audience wanted to put to Tim. So it's a great privilege to be doing this interview, Tim. And I'd like to start with one. I know we're all health professionals on this call today, but I wanted to ask a question that I think is very much at the heart of what the public want to know. And many people across the UK have been looking forward to, and of course have been promised, a normal, whatever that means, Christmas by the government. And I know Christmas isn't our only festival. We've got plenty of other festivals that have been badly hit by the COVID pandemic. But do you think not enough is being done at the moment to avoid lockdowns and allow people to safely celebrate Christmas together this year?
I think we have to realise that it's not just this Christmas, it's perhaps the Christmases for the next 5 years. We need to be thinking about realistically now that we've got a better picture about COVID-19 than we had a year ago, when we thought we just got to get over this, last winter and then it'd be fine. And that's clearly turning out not to be the case, as we realize that just vaccines alone, even in countries that have got higher vaccination rates than ours, are not the sort of final solution to this, that we need a combination of measures. We need to extend the vaccination program to include three shots. And we also need to realize there will be breakthrough infections that, how are real. We now know that vaccinated people can still transmit the virus, and that it's going to be running through our populations to some degree. Now, how high we want those rates to be is partly determined by our complacency and our relaxation of some of the rules that we had in place that last year I thought were actually over the top, and now this year I think are insufficient. And this is because we raced ahead and we had our Freedom Day in July, and in a way saying how great Britain was because we were ahead in the vaccine race. We don't need this stuff anymore, and it gave the impression of a black and white answer that is much too simplistic, as we're going to this long endemic phase with this condition that really we have to realize we just have to in some way control into something that doesn't cause as much loss of life, doesn't cause morbidities, and reduce that. And to do that is combination of the vaccines, the medicines, etc. But also we have to keep some public health measures in place to keep those numbers down. And we're not doing that. And that's why for the last 3 months we've had the highest rates not only of cases but also hospitalizations in Western Europe. And I think it's pretty unwise for a country that has such a perilous health system to be having, even at this stage, about 7% of all hospital beds full of COVID at a time when we've got massive other health needs. So we're not doing enough. we are too complacent. The government has a sort of black and white approach, and I think the public health messaging from the government has been appalling.
Yes, well, thank you. And I have to say, I'm delighted with that very thorough answer you've given. And I think talking to public health colleagues around the world, they are really appalled that we've simply abandoned all the public health measures. And of course, the vaccine, as you say, is the biggest impact, but we could make considerable progress by not abandoning public health measures. So just following that up, because I know we have members of today's audience from all over the world, I've been thinking myself about when we might think about declaring, well, it won't be us, of course, but the World Health Organization. Do you have a view about when, in your crystal ball gazing into the future, when the World Health Organization might declare the pandemic for COVID-19 is over?
Well, I'm no expert on predicting, global pandemics, so I'm way out of my depth here. But someone told me that the 1919 Spanish flu pandemic took about 7 or 8 years until it had mutated into a very mild form of viral illness, and that's really the only other similar pandemic we've had. And I think we need to be thinking into those sort of timescales. It's not in months. It's not by next Christmas. It is a question of whether it's going to be 3 years or 8 years. That kind of approach, and we're hoping that it will continue to mutate to be more transmissible. But we haven't seen it yet. But milder. There are some signs of it getting less systemic and more respiratory. But I think we need to be looking at those sort of timescales. Hopefully, it'll be fading out. It won't be all bad for the next 5 to 7 years. It will become milder. We'll get used to it, and it'll just be like having a sort of permanent flu outbreak that we have to deal with.
Thank you very, very much indeed, Tim. And I'm always fascinated by the past pandemics and infectious diseases we've had, and certainly historians would and epidemiologists have written about the Great Plague, and the only reason that came to an end because we had the Great Fire in London. So that seems a bit extreme to stop a pandemic, but thank you for your insights. I'd like to now move on to areas that I think are your specialist subject. We have a few questions on that. And I think everyone wanted to recognise the fantastic work you've done in the Zoe study, and you launched the Zoe COVID study in March. And what do you think are the main impacts of the study from your perspective? And then if you could tell us what learning that you intend to take forward into the future.
Yeah, well, it's a great question, and I could probably go on for 5 hours about all the things that we've learned from the app. So I'll try and summarize it. And I think the first thing was that we learned back in March, April last year was that you can use an app as a health tool to reassure populations and actually improve the morale, if you like, of millions of people through technology where they don't have access to a human. I think that's the thing we're learning, that actually, we slightly dismissed technology as not having that human feel, but thousands of people have written to me saying, just being able to reply to an app and to a sort of face on a picture, and knowing that this company Zoe and Kings were behind this, gave people a lot of support in a time of real fear. And I think that's the first thing that which in public health terms is potentially huge, because suddenly for the first time, people are trusting an app on a phone to really give their personal information, their health data. And this hasn't ever happened on a large scale because people have just been so frightened about data security. And we have this total risk aversion in the NHS that has stopped any real progress on digital health. So I think that's the big picture, is suddenly millions of people people that we were told wouldn't log on. People, oh, they're over 60. There's no way they can do this. Suddenly, they're doing it, and people in their 80s or 90s are also doing it. And we also learned people could do it for their kids or for their grandmas who were in homes. So we suddenly realized there was a whole surrogate network you could build up. So that's a very broad level, and I think that's going to have implications for decades to come, really, as this is the first big change in the way we deliver health and also do research, and could be potentially this a new way of accessing health, which we can come to later. But the other things, obviously, symptoms, again, very novel through an app. You tell people how you're feeling every day, and that's how we picked up over 20 symptoms of COVID, when the official ones, which were just going the old-fashioned, they were told what the Chinese told them to say, this is just a respiratory virus. They missed it all, and so we were able to get these anecdotal reports of loss of smell instantly onto the app and show that was the best, loss of smell and taste was the best single predictor of a positive PCR test. And of course, we picked up delirium in the elderly, and we picked up these cold-like symptoms in kids and gastro effects in kids, and really showed this broad range. And the last 6 months, we've been emphasizing that for vaccinated people, the symptoms are very different. They're like children. They are really the first top 4 symptoms are exactly the same as you'd get in a cold virus. So I think the symptom thing is really unique to the Zoe app. We also reassured people the first time they got the vaccines about who was the side effects and what to expect, differences between Pfizer and AstraZeneca. Would it get better or worse the second time round? And now we're doing that with the boosters. We're able to provide data on all these events with these, both what some people think as trivial ones, but how long is the pain likely to last in my arm? Will it be worse, more painful next time? Do I have to, can I play tennis after my injection? How rare are these side effects? We picked up some other weird one, amazing other side effects, like, the skin manifestations. People sent us photos via the app of COVID toes, COVID fingers, before it was recognized anywhere. And of course, some of these other chickenpox-like rashes that were happening often weeks after the event. So if you didn't have the app, it was very hard for physicians to pick up that temporal difference until they were told this is definitely linked, and therefore then it became obvious. And then people started picking up geographic tongue or COVID tongue and all kinds of other side effects that they could link back to the millions of people reporting. So symptoms was a huge part. Then, of course, we used the predictive AI aspects to try and predict who was going to get long COVID, for example. And we gave the first data about long COVID. These early stories that only affected young women really came from social media, not from systemic epidemiology studies. And we showed the likelihood of developing it, how the importance of those first 5 days of symptoms predicted how you're going to do. And there's a lot of the stuff about predicting severity and hospitalization as well came out of the app. So, and now we're looking at waning of vaccines. We're pretty much the first big UK group to show this vaccine waning effect at 4 to 6 months, despite it having been very good right at the beginning. So really high rates at the beginning. And we're able to also compare things like natural infections. How protected are you after a natural infection versus a vaccine, which again are very important, very emotional effects. So yeah, it's huge numbers of things which we discovered. The team at King's have been amazing in writing up these papers that and the Zoe team have been generating all these these big predictive models. So it's been a huge team effort, and there's many things I've not covered there, but we may want to discuss that. Having done this for COVID, we can do this for other diseases, and we've recently reconsented, and 95% of people who got it reconsented to broaden this to other common disease like cancer, heart disease, mental health, dementia, and joint disease were the top 5 that people wanted to study and give data for and give regular updates. So we've now got pretty much the largest epidemiology study outside China that are used and trained to using an app on a daily basis. So I think it's got massive potential, not only for research, but I think potentially in reshaping how the NHS could work in the future.
Thank you, Tim. I mean, you've answered that brilliantly, and you've gone on to talk about your future plans. Just 2 things I'd like to pick up. You were talking about the early signs of people having loss of a sense of taste and smell. And I can remember myself with some of the other presidents in the Academy of Royal Colleges lobbying the government to take this seriously. And it was kind of disputed. So I do agree with you. One of the members of our audience had a very, very specific question on effects, impact on hair. And you talked about rashes. You hear it's a pretty definitive question. Have you had any reports of people reporting an impact of COVID-19 on the effects on their hair? Is that something that you've had?
Yes, we've got hair loss has come up quite a lot, both after vaccines and after COVID. And definitely a sign of long COVID is people reporting hair loss. So I think this is a condition that, as it affects the immune system, can really have pretty much any effect. It's pretty hard to rule out anything to say that's definitely not COVID. Mm. Obviously, the rarer it gets, the harder it is to prove it and to link it in a sort of case control manner, as we've done. But yeah,
thank
definitely.
you. Wonderful. And you talked about, the future using the app for other diseases. I think we're all fascinated by that, and we look forward to hearing more from you. But just going back to now that we see the rates of seasonal flu and common cold rising, from your experience, is there any help we can give the public to try and distinguish the symptoms of COVID-19, given the complexity that you've described of the symptoms from those of cold and flu? Is that something?
The top 4 symptoms are pretty much identical at the moment. So that we're seeing. So it is headache, sore throat, runny nose, sneezing, and number 5 at the moment is a cough, persistent cough, all of which can happen with pretty much any respiratory virus. It's only when you get to the 6th commonest symptom, which is loss of smell or taste, that that would make it probably 95% certain you had COVID, not another virus. So I think it is very hard. What we're doing in the app now is actually working out the current rates of non-COVID viruses versus COVID in your area. And so people can statistically make a shot at this. And so in June, for example, if you had those symptoms, it was about only a 1 in 12 chance of it being COVID. If you had those symptoms in October, it was down to 1 in 4. And we're hoping to do more on the app in this way to look at that and give more personal risks. But until we start doing viral testing in a better way, it's pretty hard to know. So I think but at the moment, with such high levels, you've just got to assume it could be COVID until you've really disproven it.
Thank you very, very much indeed. I mean, one of the particular subjects that's always interested me as I led on health inequalities in the Department of Health, in the only time we managed to narrow the gap. I mean, not everyone's been impacted by COVID in the same way. And I wonder if you've got any particular reasons. We've had a lot of good research, I think, on the higher rates of COVID and mortality in the disadvantaged communities. But is that something that you've got some insights into? Because I think it's a very interesting and important area for all affected. The UK population equally, we've had this adverse effect.
Yeah, so, the UK, a bit like the US, has suffered more than you would have expected in terms of hospitalizations and deaths than other countries. And I think there's no one factor, but certainly social inequalities, deprivation has been a big factor there. And that certainly, has obscured things like the race, the question, to a large degree. You mainly explain most of it by deprivation. And obviously deprivation goes with obesity, goes with diabetes, which are also risk factors for the condition. And we did a big dietary study of over 1 million people that showed that even when you accounted for BMI, obesity, and deprivation, the quality of food had a big impact on your severity of COVID. So the fact that if you were deprived and you were having poor quality food, as is very much the case in this country with people eating ultra-processed foods, it was a multiplicative effect. And this is probably because all these things are adversely impacting the immune system through, my pet topic, the gut microbes, which we now know are this interaction between food and our immune system and our immune health. So I think it's a combination of factors, but everything is pointing to this, the food, and a lot of these things are modifiable. So that's the other slightly sad point of this. These huge inequalities in mortality we see across the country still that, other countries don't in Europe that have less of these problems. So I think, there's a lot to be compared with the US, unfortunately. 50% of our calories in this country come from ultra-processed food. You compare that with Portugal, that has only 10%. And you start to think, well, these are things we've ignored in the past. And not just deprivation, it's also a lot of the quality of British food and the effect I think it has on our immune systems, overuse of antibiotics, poor gut health, etc.
Yes, thank you. I couldn't agree more, and I think it's justifiable to say that the overall communication has been particularly poor at times and left the public confused. So trying to cut through that to give them some important messages about their, which might actually be saving lives. What you eat may save your life is very, very challenging, isn't it? So just developing on in that way, particularly, again, focusing on the more deprived populations and the at-risk groups who are not taking up the vaccine. Do you have any messages for how the government should be focusing on that and trying to encourage it? I'm a bit frustrated myself. I mean, the message going out saying, get your booster within 82 days is a sort of the worst public health messaging I've ever heard, because most people have to do their sums to work out that's about 6 months. It's not a simple message. And then, of course, our poor NHS colleagues have been inundated with people requesting vaccines, requesting boosters, who aren't able to get it because it's not 6 months since they had the vaccine and they're not in the vulnerable groups. So I think our messaging hasn't been good, but if you get any ideas about how we could really, if as you've said already, the vaccine is our biggest opportunity to get out of this mess, how do we ensure that those really needy populations that aren't sitting with nothing to do all day, they're busy lives with other pressures, how do we ensure that this deprived community and other neglected groups actually manage to get the uptake better? Messages, please, Tim. Thank you.
Well, I'm not a public health expert like you, so I'm not sure I'm the best one to answer this. But what I do know is that we forget that many parts of the country still only have around 54% of their populations vaccinated, even with the 2 jabs. So we've sort of given up on that group already, which worries me. So we are near the bottom of Western Europe now in terms of our total vaccination rates, because we were far too slow in children. And, in a way, most of them have got infected before we could actually do anything about it, because we were so tentative and worried about it. And other countries just ploughed on and have got, over 80% vaccination rates compared to our 67%. And so we've given up on that, which I think still needs public health messaging about how it saves lives and deaths, etc., let alone the booster. Because if you've got these pockets of the country that have only half the population vaccinated, they're going to keep getting infections. They're going to keep it endemic at very high levels, which is a problem for all of us. So it's not just, in my area, it's fine. These areas in East London or in Birmingham or Manchester or, wherever, we need to deal with them. And I don't think they've come anywhere close to doing that. And there's still a mistrust. And that's why they need to use some new methods. But I just feel they've given up. Other countries dealt with this by having some form of vaccine passport that said, if you want to go to a nightclub or a cinema or a theatre or a restaurant, then, you need to get a vaccine, or you need to have done a test beforehand. And many people in other countries, although they protested, they actually said, it's easier for me to just get the vaccine. I'm hovering on that edge. It just pushed them into it. And that's how they got that extra 10% done. Even if you don't believe that, it made much difference to the infection rate, it certainly improved the vaccination rate. So I think a pragmatic approach there, rather than early on the government said, we'll never have vaccine passports. They ruled everything out immediately, which made it very difficult for any public health people following up behind it to act this. But it's interesting to see how regionally this is going to play out. And what I would love is actually, if this was devolved regionally, I think it's been a national disaster. So there are very good directors of public health regionally that could make much better decisions than is happening at this very centralized approach. So, if I was in charge, that's what I would do. I'd get a lot of rude emails saying I was upsetting people's freedom, but I think the word freedom has been captured by the sort of right wing, if you like, and I think everyone has a freedom to not be frightened, and we have a freedom to try and get levels low so we can get it, other people into hospital, and that's something really important. And the booster stuff, I agree, total disaster, and people aren't getting their boosters. We're mounting up huge numbers of people waiting now. That has been in total contrast to how well the initial vaccination program went. But I think even the thought of the boost, calling it a booster, I think actually is wrong. It's the third course of the vaccine. We now know that 2 only lasts properly for about 3 or 4 months, then it starts to fade. And it's only when you've got the 3 shots, and that's what we're seeing in Israel, that once they've got that 3 shots, then everything is much easier. So I think we should finish the course should be actually the message, not get a little extra bonus on top. It's you're not properly protected, finish the course. That's how I would be pumping out messages on TV, social media, everywhere, posters, doing it in a way that is totally absent at the moment.
Thank you, Tim. As I say, fantastic comments from you. I think there might be a start of a movement on vote for Tim for next Prime Minister with some of the sense of your messages. So I agree wholeheartedly. Just thinking about the government, I mean, I have to correct myself as a UK president, because I got to remember that we've got 4 devolved nations in the UK, four nations. And, you know, we haven't got just one government, and obviously health is a big component of the other governments. Do you notice any difference between the nations? You talked about the differences in regions as far as transmission is concerned, and I agree wholeheartedly, because we had a fantastic comment in the chat, in the question and answers, about we just seem to have this enduring transmission that we can't seem to get out of the 40,000 of people constantly infected. But of course, that isn't equal distribution across the country. We do have the areas of poverty that have been, those areas of poverty were there in the 17th century, and we still got them. But in terms of the UK approach, do you notice a difference? And I mean, first of all, do you engage with the governments, and do you notice a difference?
Well, historically, the first government to recognise our app was the Welsh government, and they were very supportive at the beginning, helped us set up data linkage with Welsh NHS, and they sent out social media backing our app in a way that English NHS absolutely refused to do and still have never done. And Scotland followed shortly after that. So they were able, in a way, to think more independently and freely about what was useful, without just saying, oh, well, that reflects badly on us because we didn't invent it, or, you know, this sort of civil service nonsense that we see in England. So it is interesting how they've played out. And I think they've both made some mistakes. I mean, if you look at Wales and Scotland, in retrospect, you know, they tried things that, like fire breaks and these things, which didn't work. Wales has had particular problems with areas in its poorer region in the south that are seem to just keep producing more outbreaks, and they don't seem to be controlling it very well, for multiple reasons, I think. But they've got better, both of them got better vaccination rates than England, and I think have better public health campaigns. Scotland's doing much better and currently has much lower rates than the rest of the UK, and they're still wearing masks, and they wear masks on public transport, and I've told it's pretty well respected, unlike the UK, where it's a bit more of a placebo. And even, you know, railway staff and tube staff in London don't bother wearing them because they know no one has ever been told off or even fined in the last 5 months for that. So I think it's a different attitude, but it's very hard to make these comparisons because it's not like for like. Different densities of populations, deprivations, travel hubs, people going to work, having to go to work or working at home. It's very easy to make these comparisons, but they are different. And I certainly, people feel in Scotland that I've talked to, they feel there is more an element of control there. And even if they don't agree with it, they feel that someone is in charge. I think there's a feeling in England that actually no one's in charge. And that's certainly what I found when dealing with the politics of this early on last year. It was very hard to pin down who was making decisions. And certainly public health decisions have been very hard to work out who's actually making them or not making them. And we have a sort of invisible head of public health, rarely goes on TV or media or gives interviews or says anything, which I think is not the right way to deal with a national crisis.
And, I think it's very, very good for us to have that insight into your work and engaging with those different governments across the UK. And I think probably my single biggest, I could I could write the book about criticisms, but I think my single biggest criticism is a complete bypass in England of the civil contingencies of COBRA, who were set up to take advice from SAGE and manage major incidents. I mean, this is my 4th pandemic, and I dealt with Novichok. We used COBRA, that connected out to all the local resilience forums right across the country. It's such an effective method, but we've just, in this country, the government seems to have just bypassed it. And as you say, it's a sort of anonymous who is making the decisions and a lot of confusion. So thank you for that, Tim. There's a really interesting question we've had in, which I think is right up your street. Do you think the UK's focus on testing should shift away from PCR testing towards greater use of antibody testing, and particularly in the workplace, was the question we had from the audience.
Yes, it's a great question. And I think we all have to, we're all taxpayers currently paying for £37 billion a year, we think, in the test and trace system, which is mainly driven by PCR testing. And we test probably 3 times more than any other country in Western Europe, 10 times more than many others. So for us to pick up a case, we have to spend money, much more money. And, you know, we evolved this centralized system that ranked up very fast, very rapidly, at great scale, and involved obviously the private sector coming in and helping. And it looks like it's really hard to dismantle that, and that many people like myself believe that the advantages of having a really expensive but slow PCR method compared to very fast, slightly less accurate lateral flows that people can do at home really isn't justified now. And I don't think a lot of MPs also believe that 30 odd billion from our taxes isn't well spent. So most of that is, just so you know, under the current system, if you've got cold-like symptoms, you can't get tested by the government with a PCR test. Most of it is going to measure people in employment, in care homes, in hospitals, in civil servants, in large areas where they're tested maybe twice a week. These are people who have had booster jabs, they have high immunity, they've already had infection, they have like close to zero risk of infection, but we're spending hundreds of pounds on each person every week, and that's madness. So we need to shift some of that 30 billion to a combination of lateral flow testing and antibody testing to help us decide also who's at risk of having breakthrough infections. We did an analysis on the Zoe app recently where we looked at 8,500 people who'd had an infection a year ago and had a positive PCR test, and we checked their antibodies 6 to 12 months later. 20% had none, and the others retain those antibodies a long time. So there's a real dichotomy. Some people just do not get an immune response, so they're going to keep getting infected. And we found similar things past vaccines, that there is a group of people that just don't get them, and many of them in hospitals as well, many of the immunocompromised. We need to repurpose that wasted PCR money, that mainly money, a lot of it's going into the wrong hands anyway, and, you know, private companies that are making massive 25% markups on this stuff, and put it into a global UK antibody testing service that people can start personalizing their risk and show. And this would also help, you know, instead of a passport, you could get someone who really feels they don't want a vaccine to produce antibodies. It costs about the same as a PCR test, and we could be world leaders. So I really think that's where we should be going, and I'm trying to make it happen. But our funding from the Department of Health dried up after we were given 50,000 tests. They said, no, it's all going now to try and look at false positives for PCR testing, which I think personally is a complete waste of money. We know they do have a small false positive rate. That's not our real problem at the moment. Our real problem is having 70,000 real cases.
Yes, thank you, Tim. And it certainly gets my blood up that we spend so little on public health, and yet we say we spent 37 billion on this testing malarkey. I think the most successful bit of it was the bit that didn't get any extra money, which was the public health people, as you say, the directors of public health, the regional public health people, the national public health people, who were getting, results and following up on cases, usually to the 95% effective level. So well done on them. But what a waste of money. You're absolutely right. And I think I couldn't agree more. And I think doing antibody testing would actually, as you say, motivate and encourage people who sometimes mistakenly might think they have immunity when actually they don't. I'm just moving to my last question now, and it's been fantastic, Tim, to have this conversation with you, and what a fantastic audience we've got with all their amazing questions. And my last one, again, is something that's very close to my heart. I and the faculty produced a statement that we were very lucky the Academy of Royal Medical Colleges adopted about global vaccine equity, because, we are going to have this a long time in our own country, but the countries that don't have vaccine available really need that help and support. So do you think the UK government is doing enough to support international access to the COVID-19 vaccine?
No, I don't. And I think it comes back to this question of the 37 billion, that it is used to do unnecessary testing. And also we're giving additional vaccines to people that don't need it because we're not checking their antibody status. So I think, in a way, it links to the last question that we could very easily bring in antibody testing, and those vaccines, if someone's high, you donate your vaccine to another country that needs it. And I think it's really sad that there are countries with frontline doctors in it that can't get properly vaccinated. And I think none of us should be happy living in a country that doesn't support making that their first priority, that we support other frontline health staff, that are going through what we went through last spring.
Thank you so much, Tim. I think you've been truly amazing today to give so much of your time. It's been fantastic to get your wisdom. And yes, we've lost so many of our own colleagues in this pandemic. We should be putting them first because they are giving their lives to support others. So really a fantastic pleasure to interview you today, Tim. Lovely to have this opportunity. And I think you'd also agree we've had an amazing audience. The questions, the quality of the discussion, all of the comments and questions on the Q&A, it's just been fantastic. And I have to say it's made my job much easier. I've just got a few announcements I'd like to make, colleagues, before I close this session. So as I say, a very big thank you to Tim, and keep up the good work, Tim, and fantastic to hear you're moving into other disease areas and health matters. That's
good. So do look, if anyone's listening, do look on the app if they haven't been on it for a while. It's changed a lot. There's all kinds of new features, and try and share it with the people that dropped off it. So I think this is a huge tool, and the best way to find out about it is to use it and share it. So thanks, everybody.
Thank you so much. So colleagues, thank you so much for joining. As I say, you've been an amazing audience. The next episode of the Royal Society of Medicine's COVID-19 webinar series will be on Thursday, the 25th of November, and there will be another panel session led by Professor Sir Simon Wesley. There is also a special event on antimicrobial resistance. This will be taking place on the 23rd of November, and this will include Professor Dame Sally Davis, the previous Chief Medical Officer of England. You can also register for these events online via the RSM website. And again, thank you, Tim, so much for joining us. And thank you, everyone, for being a fantastic audience. It's been a real pleasure to have this session today. Thank you, everyone, and I'll bring this session to a close. Thank you very much. Bye-bye.